start this session because we are already late. So I'm Mélèze Ossini from Bordeaux, and it's my pleasure to co-share this session with Dr. Wichterle. And we go directly to Milan with Giuseppe and Carlo. Carlo, are you already tired that you are sitting on your chair? Okay, Giuseppe, can you go maybe start with the case and present the patient?
Of course, I think that Carlo wants to start. Good morning.
Good morning, everybody. I'm still alive, Mélèze. So can I have a slide to present the case? I'm not in pension. So to make everybody happy, we decided to do long QT ablation. I know that we have very few believers, and I selected one of the worst patients I ever met in the last year. Female, 33 years old, cardiac arrest in June, QT at the admission 533 milliseconds. Next. The coronary angiogram was completely normal, and the cardiac magnetic resonance did not identify LGE, no structural abnormalities. Next. The family history was interesting because there was a father's sister at 46 years old, died suddenly. And in the family, there was a variant, pathogenic variant of KCNQ1. This patient was implanted with dual chamber ICD and started the therapy with nadolol, but was intolerable for the patient. Even we tried the titration. So we scheduled for epicardial mapping. The last week, okay, this is the EKG we have today. This is the QTC this morning, but we will miss you in live. Next. Interesting was our attempt to better identify the substrate using the photon counting cardiac CT. As you know, is the most advanced imaging technology to identify the very minimal abnormalities in the myocardium substrate and in particular in the right ventricle. Unfortunately, the photon counting was normal in the coronary artery, normal in the cardiac structure, normal in the fat infiltration, and no myocardial late enhancement. So apparently the heart of this patient is completely normal. Okay, next. As Giuseppe described, the long QT, long QT publication, we presented the first 11 cases. Important is that all of these patients had cardiac arrest for ventricular fibrillation or polymorphic ventricular fibrillation. Important, next slide. All these patients had genetic environment for long QT. And the history of this patient started many years ago with very specific symptoms. And after about 20 years, all of them had cardiac arrest. Vai. Next. Vai. Next. These are the first 11 cases where you can see the typical localization of QT, long QT substrate. Next. Prossimo. These are the last 12 patients. Ancora. Avanti. And this is very important to talk about. We have the impression, but we need more time to confirm this data, that in most of the patients we have in different regions of the right ventricle the progression of the electrical abnormalities from double potentials to the fragmentation in other regions to the microstructural fibrosis. In some patients, we have only one aspect of these electrical abnormalities, but the typical behavior is to have in the same patient different stratification and different localization of different pattern of abnormal electrical activity. And this is the voltage map, so the bipolar map. Nothing to do with potential duration map that we usually use for the identification of Brugada syndrome substrate. We can go to the light. I sit because it's much better to move the hands. No, go to the light. So, first of all, we do the map of right ventricle. And this is the endocard. Let me see the endocardium of right ventricle, please. And you see the activation from the AV node to the rest of the right ventricle. This is the local activation time. And the impulse propagation is very homogeneous and very normal. Let's go. This is the epicardial aspect of the endocard, the bipolar. This is the bipolar, and is completely normal. So the voltage is normal. So endocardium is completely normal. Endocardium of right ventricle. Go to the next. And this is also the unipolar. And this is the left ventricle, the local activation time. Let me see the propagation of the left ventricle. The propagation in the left ventricle is very homogeneous. We don't see any block in the impulse propagation. Next. This is live. And this is the epicardial local activation time propagation. Very clear, you see that in the center of the right ventricle, we have the fragmentation of the impulse propagation. And this area is clearly identifiable with the local activation time. If we look at the bipolar, let me see the bipolar. This is the bipolar of the left ventricle. I can move the catheter in this region, so you can see. In this region, this is the present activation. So you see, this is the electrogram in bipolar. I think it is completely normal. But you see the very proximal component of the electrode. Let me see the anterior wall of the right ventricle. You see the proximal of the 9 and 10 electrodes shows the lower amplitude. And if we go in the anterior wall of the epicardium of right ventricle, we see the stratification of different class and group of potential. I want to spend more time on the detail of this potential. You see? Okay. We are in the outflow tract. See?
Do you hear me?
Tell me.
Yeah, thank you so much to showing really difference between LV and RV epicardium. While you are sitting in the abnormal electrograms in the RV, could you do some pacing to actually delay these electrograms?
Yeah, give me time. I do everything.
Okay.
Give me time. I do everything. But I want to be step by step.
Okay, go ahead.
So, first of all, in this outflow tract, we have double potential. Can we amplify this region, Luigi? No, the potentials, not the map, the potentials. Amplifica quella zona lì, sì. Let we see the potential. Very clear, we have a double potential, and apparently The amplitude is still pretty normal, unless the electrogram 6 and 7 and 8, 9. This is the first cycle is double potential region. This is the first step in the progression of long QT substrate. This is our opinion after the mapping of 25 patients. I want to remember everybody, all these patients had cardiac arrest, so we don't have asymptomatic patients. And I'm not sure to find the same abnormalities in the asymptomatic long QT patient. This is the typical situation in a patient with cardiac arrest and documented genetic and electrocardiographic long QT. If I move the cut from this region, we start looking different potential. This is a transitional zone. You see the combination of double potential with low voltage activity, and this is a transitional zone. If we go in the second circle, can you amplify can I see the entire map? Beniamino, show me the entire map. The entire map, okay. So very clear, the second circle is associated with very low voltage potential. See, in the 3-4, we have a typical fibrosis corresponding to the red color. But I want to emphasize the photon counting was completely normal, and the MRI was completely normal. But this is clearly a different potential from the normality. And unfortunately, we are still using not the best catheter possible for the mapping. We are waiting catheter with high density map like Optrel or HD grid, because with this catheter we can better visualize this activity. And the second circle, the third circle, is a typically transitional circle with double potential and little fibrosis. Just to see the difference, I move to the left, and to the left, the activity is completely normal. So for sure, in this patient, we have very normal endocardium, very normal left ventricle, and this pattern of substrate seems to be a right ventricular dysplasia, not detectable with the MRI. And the only clinical manifestation of this substrate is the long QT. Can we measure the long QT, Beniamino, in real time? Give me the QT of this patient. The QT in this patient in this moment is corrected QT. Okay, is 588. So we have genetic mutation, family history of sudden death, long QT near 600, and cardiac arrest. So, as you know, it's very unusual to have a patient with QT and cardiac arrest. And we also, in this case, have to admit that the only phenotypic expression visible at the eyes behind the direct mapping is the QT prolongation. So my question is this condition a variant of right ventricular dysplasia, or this is the most advanced progression of long QT? We will discuss later. So now I would like to stimulate from each circle, just to make happy MLS.
Thank you,
In the
Carlo.
past, QT was considered a repolarization disease. But let's see what is the behavior stimulating from the substrate. Let's see if we have the enhancement of the fragmentation or the normalization. Puoi stimolare, Beniamino? From 1, 2. Yeah, this is the region of double potential. Can you amplify the electrogram to better visualize and try to capture increasing, try to capture. No, devi catturare. Aumenta l'uscita, aumenta l'uscita. Aumenta l'uscita e anche la frequenza. Yeah, you are capturing. Sometimes not. Aumenta l'uscita. Eh?
Okay, we are capturing regularly.
Okay, very good. So we have just a little increase in the fragmentation when we capture. But I want to move the catheter to the second circle. In the second circle, we are exactly on the fibrotic area. Try to capture if it's possible. Ancora? Try to capture. It's not easy to capture on the fibrotic area, but we try. Okay. Little more. What do you think, Melez?
Thank you, Carlo. I think I would probably pace from the apex of the RV and send some extra to delay the second potential. Do you have...
but usually... Yeah, okay.
And the idea also is to see, I don't want to disturb you while you will
let's
do... You will
stimulate
do
from here. Let's stimulate from here. Bye.
Yeah, the idea is really to see that it is a functional substrate.
Yes, yes, but it's not functional. Clearly, it is...
just demonstrate that.
It is fibrosis. It is clearly fibrosis. And we have a little increase in the fragmentation, as you see, very clearly. But we can go with the endocardial catheter. Let me do. And this is. I need to go in the right ventricle. Vieni giù. Vieni giù. Ma vaffanculo. Tiro fuori, vai. Aspetta, si è bloccato. State fermo, aspetta. Dai, non rompere il cazzo. Ok.
For the effort.
Aspetta che mi let me place just in the middle. Okay, do the stimulation. Do the stimulation, aumenta l'amplificazione. Aumenta l'amplificazione dei potenziali.
Yeah, some extra bit, that would be perfect. And then I think you can move further for your ablation procedure.
We can also see them from Carto.
Let's increase the voltage. Ok, vai. Ok. Okay, perfect. So the first question, I think, the most important thing in this story is to admit the existence of a substrate of long QT in case of cardiac arrest. And in this particular patient, the mapping of the right ventricular epicardium is extremely important because it can be the place where the ventricular fibrillation starts. I don't want to say that 100% of long QT patients have this substrate, but for sure 100% of the patients with cardiac arrest and long QT have this typical substrate. So what is our approach? Our approach is to preserve as much as possible the normal substrate. But in this case, we have a very extended substrate from the outflow tract to the anterior wall with the most advanced substrate to the region near the tricuspid valve. But this is not the typical localization. And in the previous cases we did, the most frequent localization was the tricuspid valve. In particular, the epicardial aspect of the tricuspid valve. And it's not frequent, the localization in the outflow tract. Indeed, if we look the previous study from Belassen, he described the morphology of the torsade points, and the morphology was not from the outflow tract, but from the anterior wall and the inferior aspect of the right ventricle. So this distribution of substrate is compatible with the morphology of the torsade point and the polymorphic VT in this specific patient. So what you would like to do in this patient? I have in mind what I do this morning, but what is your opinion? What you would like to ablate? First circle, second circle, or third circle? All together.
No, I think it's your patient, so we are in a life case, so you do the best for your patient. And you start the ablation as you used to do.
But I want your opinion.
Yeah, I mean the opinion.
I want your opinion.
Basically, it will be a kind of homogenization of the area and try to eliminate these abnormal electrograms with a very high power, short duration, staying at some site very... have really short duration to RF to avoid any deeper lesion. So it's kind of brushing the epicardial, probably. So go ahead.
Yes, this
Carlo.
is what I'm going to do.
Right.
Exactly what you said I'm going to do. Because from the previous patient, 100% of them, not 70%, 100% did not show any further ventricular fibrillation or syncopes. And regarding the QT prolongation in this patient, for us, it's not important to reduce the QT, but to eliminate the substrate. Because in our opinion, the ventricular arrhythmias are related to the substrate and much less related to the QT prolongation. In any case, the decortication of the epicardial aspect can provide, as consequence, the QT shortening of at least 10–20%. And this effect persists, in our experience, for 3 years at least. So I don't know if in the next 10 years it will change, but the possibility of the regeneration of the tissue, it's very low, because we need a century to reproduce the same substrate, as you know from the molecular biology.
Carlo, just before
Yeah.
you go for the ablation, any thought? Your team can maybe probably show us a 12 ECG again. Any thought on this
Yes,
kind
sure.
of ST elevation in inferior leads? Are there any
We got that.
abnormal
I show you.
electrograms in the inferior RV? Because on the 12 ECG, we can clearly see that there is a kind of J wave. I know that there is sometimes an overlap, as Giuseppe have nicely shown earlier. So what are your thoughts?
But in my opinion, from the experience of this case, we have different prolongation of QT in different leads. And in all these patients with this type of substrate, we have a specific highest prolongation in a specific lead. It's not always the inferior lead. Can be the anterior lead, can be the lateral lead, can be the inferolateral lead.
Yeah, I understand.
Because
but in that case,
the QT prolongation,
it's in the inferior leads.
We see now, I show you, let's amplifica l'elettrocardiogramma and
You see?
amplifica l'ECG.
There is a J
Can you
wave.
amplify the ECG?
Yeah.
The light?
It's often associated.
Ok, amplifica ancora l'ECG.
Okay.
La telecamera può amplificare l'ECG?
We can see it clearly on the left
telecamera.
side, that you have this kind of J wave
Yes.
in the inferior leads. Right.
It's at least 2–3
Yeah,
millimeters
we have
elevation,
in
base
AVF,
point elevation.
We have in lead 2, lead 3, and AVF a little early repolarization.
Right.
So typically, these correspond to the substrate localized in the anterior wall and inferior wall of the right ventricle. So once again, we have the electrocardiographic and anatomical demonstration that long QT is not a simple electrical disease, but is a regional disease associated with a very typical substrate. Interesting will be to see, after the ablation, if the early repolarization changed a little bit,
Yeah.
and if the QT is also reduced.
Yeah.
Let's see, and we can start the ablation. Let me change the cut. I just can show you the way we do the ablation. So the
Carlo?
lesion is very short.
Carlo, you also,
Yes, yeah.
identified some substrate at inferior wall according to color-coded map. Can you revisit this area, or do you
Later,
plan to
later.
ablate also this area, or only this like RV free wall?
I will do the ablation also of this area. Let's show. I need to go better in that area of better steerable catheter. You know, let me go with a steerable catheter to better see. Mostra la mappa.
Actually, you see there, we interpreted those red area as the distribution of the right coronary, actually. But certainly the inferior area has shown some fractionation, and actually we completely agree that there is this abnormalities also there, and this might be suitable
but it's
for
coronary artery.
no, not there below, but where you have the catheter right now.
Let me go. Fammi vedere in anteriore, Beniamino, non fai vedere la coronaria, che mi interessa.
But again, this is a very important aspect.
Let's see. We have a double potential, not a big fragmentation.
Over there. Okay.
Over here, we see this is a region of interest. We have a double potential. We have a double potential, see? Double potential. So I think the most advanced substrate is in the middle. The less advanced is in the outflow tract. And the transitional area is the inferior part of the substrate. But before the first circle and the second circle, we have the transitional zone. So this means that over the years, this transitional zone became fibrotic. It's just a question of the time. As I told you at the beginning, most of these patients start having syncopes and mild arrhythmias or conduction disturbances 20 years before, and the ventricular fibrillation occurred at a late stage in the natural history. Usually patients have at least 40 years. I know the long QT is considered a disease for the very young people, but our impression is that the most severe arrhythmia occurs at the late follow-up. So now we start the ablation. Giuseppe, can you say how we do the ablation and what is the setting of the power and everything?
Well,
So I am sitting to be very precise and avoid to ablate very normal areas. So we have the continuous extraction of the fluid from the pericardium. Puoi far vedere questa linea? Questa linea che arriva il liquido? It's extremely important during the ablation to see the line from the pericardium pretty white, so no blood inside. This is crucial. But show now.
there is a little bit, but it's
Fai vedere. It's very clear now. Let's see. It's very clear. No, let's go. Amplifica sopra e fai vedere che il fluido è very clear. We don't have
staining of blood.
sì, now fallo vedere meglio, avvicinati, sennò sembra che c'è il sangue dentro, invece non c'è.
Vabbè, non riescono perché non ha contrasto, è troppo scura la stanza.
Non c'è contrasto nella stanza. Illuminate la sala, così si vede meglio, sennò sembra che è sangue quello. Invece non è sangue. It's not blood. No, tutto il contrario. Luce.
Beh, piano.
Luce.
Yeah, but don't worry, Carlo. I mean, you are in charge, so you know what is the best for your patient.
Go.
If you say it's clear, huh? That's it.
Ok, vai, go.
Don't spend time on that.
Vai, go.
Carlo, we have 4 more live cases in parallel with this, your case. So maybe if we will leave you ablating and we'll come back in 30 minutes, or is it okay for you?
Okay, perfect. Okay.
Just one question,
Right.
Carlo, before leaving. I see that when you do ablation, your vector is pointing toward the pericardium and not toward the ventricle. Is it a strategy or?
No, the vector doesn't mean anything because does not correspond to the reality.
Okay.
What is important is the red dot, the red you see on the Q dot sensing. And red means that we are in contact with the tissue. See.
Okay, thank you,
Okay,
Carlo.
bye.
So we come back later. Good luck.
Yeah.
So can we switch to ICAM, Peter Peichel case? Is VT
Hello. Do you hear us?
Yeah, I can hear you, I can see you.
So welcome back. We are here with the first system for VT ablation. I'm here with Predrag Stojadinovic, who is our colleague, and we in general anesthesia started a case of VT ablation, and Predrag will introduce the patient for you.
Yeah, so as Peter said, this is a case of catheter ablation in patient with post-myocardial infarction, VT, we will do this case with probably most sophisticated system which is currently available. It's a FERA, and our patient is 71 years old, male, with few comorbidities. He has a ischemic cardiomyopathy, and many years ago this patient had a myocardial infarction that was treated with POBA, and few years after this he underwent surgical revascularization, and he has a mid-range ejection fraction of 40-45% with inferolateral scar, and he has a mild aortic stenosis. Can we go to the next slide? And 1 month ago, this patient was presented with sustained monomorphic VT, and after amio administration, he went into the cardiac arrest, so he was cardioverted, and on the ECG, he had transient ST elevation, so we did CAG, and that revealed patent lima and other venous grafts were closed. So a patient underwent a single chamber ICD implantation as a part of secondary prevention of the sudden cardiac death, and he was scheduled for catheter ablation. And here you can see the VT with superior axis, positive lead 1, and transition zone between V3 and V4, so site of exit of this tachycardia is probably mid-inferoseptal part of the LV. And now I will show you just the eyes.
Can we switch to eyes?
Switch to eyes, please, on the big screen. Yeah, we have it. Okay, so here you can see the scar in the inferolateral wall of the LV. Ejection fraction, in my opinion, is less than 45%, and you see this echogenic strip that is basically that represent this scar that is transmural. And also, if I clock even more, we can see the short axis with aortic stenosis. This stenosis is also not mild. It's more like I would say it's almost more severe. And we did induction, and Peter will show you what we were able to induce.
So thank you very much. Just the echo shows you that just for those that are not using the technology. So maybe if I just rotate slightly, you see hopefully if you go back just to echo, just have for people to have a kind of reference. I really like echo because even if you start up front, you know where the scar is usually. So here you see a kind of homogeneous inferior lateral wall. If I just rotate slightly, you immediately see both the sphere 9 catheter, which is now, and it's very recognizable on the echo. But you can see also the scar, which is of the white strip within the tissue. It's not it's subendocardial, but it doesn't. It's in the mid-myocardium, I would say. Okay, so first, when we started, can we go back to Pruka and we show you what? So the patient has something, clinical VT, documented on 12-lead ECG, and yesterday we had a case of post-MI, and immediately when we inserted anything in the LV, we got VT. This is the completely opposite situation. Although he has a kind of documented 12-lead ECG, we cannot really induce much. Or we could induce very polymorphic VTs with aggressive pacing, and this is one of them. This is changing. If we go to number 2, this is the most monomorphic VT we could really induce. So just to have a comment about this, it terminates spontaneously. But you see it's negative in 2 and AVF. It's very negative in lead 1. So it's more lateral, inferolateral, I would say. And it's more apical because the transition zone is V2, V3. So it's more apical. It's definitely not basal. Both clinical VT and this inducible VT had a more apical exit. One is more posterior or inferoseptal. One is more inferolateral. So we start to do the mapping. So maybe now we can change to the FERA. I'm just I'm lost from yesterday. So can we see the, and maybe get it smaller and just rotate for the audience. So we spent some time to get the voltage map of the LV. So this is what you get. This is 3,600 electrograms all over position. So it's a very high density mapping. And you see, we use the standard criteria. We don't know whether with this system is for ventricle is the optimum, but let's use this for now because it corresponds nicely with the potential target is. And there's a definite inferior scar with some markings, which I will explain. The red area is quite large. I believe it's definitely not the idea here to paint it all red because we will destroy a lot of myocytes, maybe not necessary, so we should have a strategy. So what is the strategy here? So we just marked, and if you remember, we had a VT1, the clinical one, which was documented 12-lead ECG, and we have VT2, which was the one that was not sustained, was more monomorphic. And we marked that pace map for those VTs that kind of resembled on the map. So we have one part of the scar that corresponds to one VT. We have the other scar, or part of the scar that corresponds to the other VT. So let me show you some electrograms. So if we go back to the review Pruka screen, let's wait for that. So go number 3. So we somehow pace map the non-sustained VT2, we call it. There's not long SQRS, so it's really on the exit side of the scar. So maybe number 4, which we marked. And this is more likely the two kind of VT1 pace maps with a longer SQRS. This is even better with the number 5 we marked. So yeah, please click on this. So this is more resembling the clinical documented 12-lead ECG, and they're more posteroceptal, also apical. So then we move the next one, which is the late potential, and we really look for the late potential. So maybe if you increase to 200, so this is in the central zone of the scar area. This is the signals you can get. It's a little bit different what you maybe used to from the HD grid or multipolar catheter because it's a sphere. It touches the endocardium only partially because it's not covering the whole. If you have a flat kind of catheter or if you have an octave, it just covers all of them, represent the signals. Here you see only the distal shows, but that's good enough because it's still multipolar. You can use these are definitely late potentials. We also pace from the right side. Can we go for number 7? Which gives you this is extra stimuli, not this one, the previous one. So can we move a little bit to the left? Not to get a little bit to the left. Okay, so this is one extra 300 milliseconds, and you can see the kind of delay activation. So you can use this catheter for deep mapping very well because it covers a kind of larger around the kind of portion of the surface is this 9 millimeters. So it gives you the option, and definitely this would be the central zone of this. If we go for the next one. To show, and in the central zone of the scar, we have a very long SQRS. The morphology doesn't match because it's probably exiting more basal. If you look at the ECG, you see the positive from V1 to V6, so this is the basal exit, but the central zone, obviously, this is very kind of slow conducting zone. So now if you go back to the Afera map, just to summarize what we have done. So this is the scar. The red is lower voltage is much larger. We don't want to really create too much damage. With this system, it's probably possible to really do extensive damage. Let's not do that. Let's focus on the most juicy part, which is the slow conduction zone with the decremental properties. Trying going to the exits of the VT1 and VT2, which we currently demonstrated. So any questions to what we have done and what's the late potentials obviously on the map are the late potentials. Any questions up to this, and then we can discuss the strategy.
Any question from the audience? No, thank you, Peter, for nicely presenting your patient and the EP data. I think you can explain a little bit more your strategy when you will start to do the ablation. Electrograms are really great. So basically,
this is just we try to limit the ablation. I believe with these large tip electrodes, you can do extensive damage, and that's not the point. Let's have a good strategy because it's very easy to do a lot of distraction, but let's focus on what's important. So I believe the late potentials going into these two exits, maybe the one for the very longest QRS, is the one target. And the question is what we're supposed to do as an energy source. And the system is very versatile. It enables you to use both RF and pulse field. The RF takes a longer, you can go 30 seconds up to 1 minute, so just slow cooking. So there's not the power output is not as high as in atrial level because there's a high power, short duration. This is like a lower power but longer duration. It's temperature guided. So when we start to do it, we will show this, the temperatures and the kind of attenuation of the power to do. The other option is to use pulse field here, and it's 5.5 seconds application per application time. And then you stack those lesions on one or the other to generally get the maximum output. Generally, our approach in this post-MI is to use first RF. And there's several reasons for that. We don't really want to, the pulse field is still something that we want to study slowly. Don't rush and just pulse all the ventricle because I'm still very afraid, as I was talking in the morning, not to have too much stunning. And the problem is if you use pulse field, you wipe out electrograms. And we don't know really whether this is good enough, whether this will be reversible, irreversible. With RF, I believe we are pretty kind of confident that we know what we are doing. So our approach first is to use RF on those areas that we think it's important. And then if it doesn't work, if we still have a VT, then use pulse field as a second option and limit the pulse field. That's our strategy. Currently it may change, obviously, but this is what we decided to be more on safe side, not to overdo it with the pulse field.
I like this wise approach, definitely.
Okay, so I'm happy because you also have the system. So we may obviously discuss, but just to rush in and just do all the pulsing, it will wipe out the electrograms.
Yeah. Could you show us the intracardiac echo while you will deliver RF to see the whitening of the tissue?
Okay, intracardiac echo. We will show, and we start to, because RF we really like this. Yes, the RF will be. And we do one lesion 30 seconds. So let us first to start the system. We still don't have the preset of the RF. Máme, prosím, někoho z aféry, kdo by nám dal RF? Yeah. Okay, so let's go. So we start to apply, so go on. So this is flushing.
Yep.
And this is the application. So hopefully you see the bubbles, but there's the flushing of the saline, which is increased to 30 mils per minute. So this is, and we stay for 30 seconds. We can go up to 1 minute. So far we go with 30 seconds, and we will see. Maybe we can extend it if we are not successful.
Yeah. We can see already tissue changing.
So we also look at can we record this on Pruka? Are you kidding me? We are not recording? Okay, so the signals doesn't disappear completely. So can we see the signals prior to ablation and after? Do we have some recordings? So on review, can we? So these are the prior ablation, and we can we increase to 200? Maybe to appreciate. Maybe we can put it side by side. Just give us some time to really have the afterwards. They're still there.
This is prior or after?
Yeah, just let us, they're working on it.
Yeah.
I will kill them because we start to ablate, we didn't record prior, we didn't record the ablation.
This is life case.
The point here is to show that they're still there. They didn't completely disappear. And we can do on the top of it, just to see what the difference in the ventricle, do one pulse field 5.5. Just, we will use it very rarely, but for this one, let's do it here, just on the same spot to see what the electrogram will change.
Yeah, and during the meantime, can we see still the echo, really to see the difference in the tissue characteristic?
But there's a different queries morphology, so you cannot really compare those two.
Tu levou změň.
Tu levá je špatně. Levá je špatně.
Levá.
This is the different, they're changing QRS morphologies.
Yeah.
So, okay, they did change. There's not that dramatic change, but there is a change.
Could you check?
But kind of delay.
Could
okay,
you check
this
local
one and
capture?
after. Can you keep this one? Okay, this is prior and after.
Yeah, it
So
will
there is an
capture.
attenuation of electrograms.
Yes.
It's a 30 watts. Can we review the ablation on Afera to see how many watts we applied, what was the temperature, and how was this, I believe it's important just to go into the details now.
Yeah.
So maybe go for the Afera screen and enlarge the application to see how this was. So generally, if I correct, so we have a set about 55 degrees or up to 60 degrees, which is the orange line, okay? And we somehow attenuate the current when we reach the temperature. So as a temperature control, something which we use from Diamond Temp, which we use for Q dot, which titrates the energy. You can see also the impedance drop that there was some in this car. So this is
Do you have,
exactly what-
Peter, do you have an
Yeah.
idea of the current density using your setting that actually that exits from the catheter?
Yeah, because the surface is much larger, they say the current density is much lower than we use for 4 millimeter tips. So the chance to have a tissue overheating with RF is much less because the current, although it's much higher, is spread over much larger area. But we also measure the temperature, which somehow, as you see, the violet color hopefully goes down, which generally means that it is the power output of the generator, which is displayed in percentage. So we started with about, I don't know, 40% of the output, and then it went down, and one point down when the tissue overheated.
Okay.
So any comments to this temperature control, power delivery of what is for 30 seconds? This is the RF. This is what we know. Yeah. And there was some attenuation of the potentials, but maybe not that complete as we would expect.
We have a question from the audience, Peter.
Yes, please.
One question I have, I was just using this Sphere 9 last week on a in vitro, and we were told that just a 4-second RF application, and I did it actually for 4 seconds, and I was able to get the 18 millimeter lesion. So, but here I see that you go for 35 seconds. What's the difference here? Because we were told that you can just do
very
either
important.
4-second RF or 4-second PFA. Thank you.
So this is very important. This is a special setting for ventricle lesions, and it's a longer because if you need a depth, you need to stay at the site a longer time. If you do a lot of current in the 4 seconds, it works for some lesions, but if you go in the scar, so this is a smaller amount of slow cooking, I would say. So, yeah, and this one, if you go up to 1 minute, it can go up to 1 centimeter in the depth. In the fresh tissue, in the scar tissue, it might be different, obviously. But this is a special setting for the ventricle, this 30 seconds RF. So it gives much less power than it does in the atria when you want to do shallower lesions. Shallow lesions are enough, actually, for do. So if you use 4 seconds RF or 5 seconds RF, they are much more power, but shorter amount of time because you don't need the depth that much. Here you go really into the depth, and for that you need the conductive heating from the tip of the catheter into the tissue, and it takes time to cook the steak well, as we know. So this was the RF. Is there clear? Because in atrial level we will use the different settings. So is this clear?
Yes.
Yeah, it is. Thank you.
Okay,
I
so
think
now
you can
let's
go
do
ahead
just-
for the ablation.
Yeah, Peter.
So let's do one. So we can record the electrogram now, just to have an idea, and then we go ice.
And then we
Can we
move.
go ice just to show the pulse field application? That will be just 5 seconds.
Yeah. Peter, can you hear me?
Yes.
Could you please check the local capture at the ablation site, and if there is any...
Okay, that's a good
you
idea.
may
So
reablate
can we
by
go and
PF.
before we do with the after 30 seconds or RF, let's go of the local capture. Can we paste from the ablation just to see what's the spacing threshold? From the Sphere 9, can we paste? Can we show the online Pruka? Leave it like this. Online. Just leave it like this, please. And just show the audience the online.
Yeah, live screen.
I mean, we had a very long QRS. It said this 30 seconds, even the electrogram didn't attenuate to the completely. There, you have no capture, so there is a lesion. You agree?
Yeah.
Yes, please. It would be nice if you select the other side and show us at least one single PF ablation, and then we will switch for Homolka Hospital.
No, nobody. So we will just maybe go a little bit kind of closer to the one and see what's. Just let me just change the position more to the kind of late potential area. Let me just work on this a little bit. I want to go into the center of this. So maybe we are closer to the VT1 exit. So now just online screen. So if you just store this as electrograms prior to pulse field ablation. Can we store this? Okay. So now
Pace,
we maybe paste just to see whether it's capturing. Okay, it's capturing with the also longer SQRS complex. Can we see the morphology just a little bit? So it resembles not that much the VT1, which is more apical, but there is a still longer SQRS. So can we now store and put a echo up just to make what happens during the pulse field ablation? And we will do one pulse field. Can we change to pulse field? 5 seconds VT mode. Okay. Okay, so echo, and now we do 5 seconds. This will be very short, so let's do it. So we record the electrogram and show it prior and after ablation. Okay.
Gone.
And show us the electrograms, please. Now, the prior and after. But as Hiroshi was saying, what does it mean that you get rid of the electrograms? I mean, there was no capture after RF, although the electrograms was still you have some kind of, once you start to pulse, you wipe out the electrograms completely. Let them work on the electrogram quality. Just make it the same QRS complexes because we have a changing morphology of the QRSs. So this is prior, and just move, this is after, more or less.
Can we paste?
Now can we just do now just store maybe in the, and we can also paste to show you that there is no capture. Live, you just keep casing and
show us live screen, please.
Live screen, yes. It's a kind of time-consuming, and there's also no capture. But so you can use both. But generally, our approach is first to work with something we know, and the problem is with the pulse field, you really get rid of electrograms, so you don't know where you really did it. You really deep in the depth. That this is something that has to come to really know what the depth is. Maybe with some data that we have. With the more in the future, but with RF, we still know there are still electrograms, so this is something we can rely. So this is our strategy. So
Peter,
was this clear?
Peter,
Is any comments to the pulse field?
No, I think it's quite clear here. We will leave you going what you have to do, continue the ablation, and we will move to the other lab. Vivek is waiting, I think, and we will come back to you, Peter.
Perfect.
Thank you so much.
Now we are connecting to Homolka Hospital. Can you hear us, Vivek?
Oh, is it? Oh, okay. Yeah. Hi. Can you guys hear us?
I can't hear you, Vivek. I can't hear you. I can hear you. Yeah, but yeah, perfect.
Yeah. Let's go ahead and start the slides. Can you guys hear us? Don't worry about it. We don't need to. Yeah. Go ahead. Okay. So let's just. I know we're running out of time, so we'll go through this fairly quickly. It's a 55-year-old patient, and he has persistent atrial fibrillation, as you see. He also has a history of documented typical flutter, and you can see the ejection fraction is preserved. He has some left atrial, which is mildly dilated. Shut up. He's been on, he was on amiodarone in the past. He's on Xarelto. Next slide, please. This is the EKG, and actually, let me just take you, let me tell you our plan in this patient. In this persistent patient, the goal was to do pulse field ablation to treat the atrial fibrillation. We're going to be using the pentaspline catheter, this is the Fairwave catheter, to do PVI, posterior wall, and CT isthmus ablation. Then, in addition, this patient is part of a protocol where we're trying to sort of establish or determine the extent of epicardial, let's say, extent of the posterior wall ablation. So our plan is we do pericardial mapping, particularly focused on the posterior left atrium, pre-ablation, do our regular ablation endocardially with the pentaspline catheter, and then remap on the epicardium to see whether or not we have full thickness. Now, again, because of time, we're not going to show everything, so let me just tell you what we've done. We got pericardial access, again, with the Rook pericardial access device. Some people asked me yesterday where you get this. Again, this device does not have regulatory approval in the US or Europe. It's manufactured by Circa Scientific. The devices are shown there. Next slide, and I'll just take you through it very quickly. It has this tunneler and obturator that you push to the heart. Next slide. And then you have the device itself. The device actually has these hooks that capture the pericardium, then you pull back to retract, then you puncture with the needle, and you advance a guide wire through the needle to establish access. Next slide. So again, this is a tunneler obturator. Usually we'd like to do it in a lateral view, advance to the heart. Next slide. We put in the Rook device through the tunneler. Next slide. We inject a little bit of contrast to define the outside of the pericardium. Then we capture with the little hooks. Next slide. Then we pull back to retract the pericardium and then puncture with the needle. Next slide. And then we advance the guide wire in the pericardial space to get access. So let's go live here, please, and show what we've done so far. Yeah, if we can show the fluoro and the cardo. So if you look on the cardo screen, why don't we go full on the cardo screen? So as I said, we got pericardial access, and you can see on this PA view, so I should also note this patient has a PFO. So we went through the PFO, mapped the left atrium, rotate around AP, please, and you'll just see there's the AP view, and then a PA view again is good. And then the other thing that you're seeing on the right screen, that's actually the pericardium. And actually, can you bring it up on the left screen also? Okay, there. So you can see where the pericardium is. Again, quite healthy looking. We went in the oblique sinus all the way up, and we mapped as much as we could. So this is our baseline sort of situation.
Vivek,
so now,
Vivek, the pericardium was mapped with the Pantaway?
Yeah, sorry.
Oh,
yeah,
right.
yeah.
Okay.
Told you that. If you show the four screens, we can go to the, yeah, you can see there, MLS, so actually I'll just show you very quickly since we're here. So we have a short coil Agilis catheter in the pericardial space, and there's the Pantaway, and we just put it in the pericardium as you see there. Now during ablation, I don't like the idea of it being there, so we'll pull it back and just leave it out of the position. Now, as I said, the patient has a PFO. We do not like to use the PFO to do the AF ablation because it takes you too far anteriorly and superiorly. It just is very counterproductive. So what we're going to do is we're going to puncture in a usual place. And in this particular case, we're going to use the powered guide wire. So let's just show you how we do this. So this is how I like to do it. There, we're going to pull the guide wire back in. Actually, I like to do this with the sheath itself because that's the safest way. So here you see on the ice, again, we like to use ice because ice is nice. Here is, you can see the sheath that's tenting, and I sort of like this position. It's not too posterior. It's sort of pointing toward the left veins a little bit, maybe slightly anterior to it. I advance the dilator a little bit. If you see on, let's use high quality. Oh, that is high quality. Okay. Anyway, you can see the dilator just poking through. I'm going to put this here. Let's buzz across. Oh, you want to do it? Why don't you do it? Okay. Bzz. Okay, that's good. And so one of the nice things about using this kind of a powered guide wire is that, well, you get very good, you can puncture exactly where you want. You don't have the situation where, let's take this out, where when you use a regular needle, for example, as you advance it, sometimes it glides up a little bit, which is disadvantageous. Here you puncture exactly where you want to. Of course, the downside is it does have a cost. So anyway, we now have access, and we're going to go ahead and put our pentaspline catheter in. Let's go ahead and aspirate. One thing that's really important, you got to be, I think everyone knows this, but you got to really be careful about introducing air. So every time we advance or retract any catheter out of the sheath, we always aspirate the sheath. I cannot overemphasize the importance of that. Okay, let's put the guide wire in the superior. So we're in the left superior, and what I want to do is to just show you, I mean, we use ice quite a bit, and I'll show the ice here. But I want to just show you, to me, when you do the left veins, I actually like to do a smaller sort of basket or olive, whatever you want to call it, your terminology. So they're actually touching, because it's very important, I think, to get good investiture circumferentially. Okay, let's go ahead and start here, please. We deep? Okay, good. So, ablation, please. Yeah, go ahead. So we have a bunch of stuff to do, so I'm going to go ahead and just get going here. So our strategy in the left veins, again, I like to really have the, always double, please. I like to really have the smaller basket or olive. Okay, let's go, please. And then there I rotated, and we'll do another one, because I really want to make sure we get PV isolation. Yeah, Martin, just go.
So, Vivek, while you are ablating, did you give some atropine? What is your...
Yeah, actually, we gave atropine much earlier. Martin, go. Oh.
And can you comment on the level of ACT?
Yeah, the ACT, we like to have it, my CS just fell out. We like to have the ACT sort of like around, whatever, about 300, closer to 350 is preferential.
Right.
So we gave the atropine much earlier because actually it was going very slow and I wanted it for the, I just wanted to make sure. Let's go on again. So I'm going to do a bigger basket here. Go ahead, please. And the reason, again, on the left veins, I actually like doing the olives and then a pair of baskets because I just feel like you really got to make sure that you get that ridge with this. Martin? Oh. And now I'll do my, my flowers. So let's advance the wire a little bit. Okay, so then I like to do this. And go ahead, Martin. When you do the flowers, I think one of the things you really got to pay attention to is where the petals are. Now, in this particular case, it's not going to be as critical, let's say, because we're also going to do a posterior wall. So a lot of this stuff we're going to end up getting later anyway. So I don't care as much.
So obviously, Vivek, when you do your ablation, you are not really concerned of having a petal or any electrode inside the vein. It's not a concern for you at all, right?
I don't care. Do two more. So yeah, you're absolutely right. Well, yes and no, Melis. On the one hand, from a safety perspective, it's a non-issue, as you point out, okay? But from an effectiveness perspective, if I have a bunch of petals inside, then I'm not going to be ablating where I want to. So that's one of the issues. Okay, so let's go. I'm going to pull this back. We're going to cannulate the inferior vein. Wire back, please. Okay, let's go ahead and advance it. No, we're back a little bit. I really want to cannulate the inferior vein. Yeah. Okay. Okay. So again, it's going to be like an olive type thing. I really want to make sure I get inside because my biggest concern in doing these is that we don't get the ridge well. Okay, go ahead, double. Is that we don't get the ridge. So what we've done in the left superior is 2 sets of olives, so total 4 lesions, then 1 bigger basket, and then 2 sets of flowers. What we're going to do in the inferior, we're going to do the same type of thing. So ultimately, we will have ended up putting 10 lesions per left side. My right-sided strategy is different. I focus a lot more on the flower than I do on the baskets. We've done 2, right? Okay. 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 Go ahead. Yeah. And 1 more, please.
Can you comment, Vivek, obviously using the ice, you can see the tissue characteristic. Are you using ice only for manipulation and contact, or you also pay attention to the tissue changes?
Let's go ahead there, please. I would love to say that I could see the tissue, Melez, but I can't. I mean, I see that I have the catheter close to the tissue, but actually looking for tissue changes, most of the time I can't. Yeah, even in the ventricle, I got to say, I really can't most of the time. When we sometimes see it, it's like, wow, we're seeing something. But I think that, I mean, in my mind, if we really want to look at tissue characteristics and things like that, we're probably going to have to use other strategies. It's, some of the other strategies. Okay, now we're going to do, so we've done a total of 6 lesions so far in this vein. And so now, See, sometimes the flower is forward. It sort of leans forward as we see here. And when that happens, I don't really like it. I really want to make sure that my, okay, there, that's a little bit better. Okay, go on there, please. Again, I'm less concerned here about the flower because I'm going to do the posterior wall. So a lot of the, even though it's leaning a little more forward than I would like, I'm not going to stress too much about it. You know, one of the interesting things is there will be a, the pedal is coming backward. There we go. Let's go there, please. There is the so-called fair view system where the magnetic sensor will be enabled in this catheter. You can see it on the arrhythmia system. I think that will help because in addition to reducing the fluoro time, I think what will end up happening, are we done with that one? Well, okay, so now let me go to the right side. So what I like to typically do is pull this back and go to the right inferior. And we can look on ice. So there it's pretty close. So we slowly advance the wire. Always do that very slowly because if you're up against a tissue, you could have bad things happen. When I do the right inferior, I like to use an REO view because in the REO view, so here, clearly I'm in a bad position. You can see the two of the pedals inside the vein, right?
Yeah.
So
Correct.
we can reposition. I just rotate there. I like that position. If I look on ice, it looks pretty good on ice. It's not perfect. There, it's not bad, actually. So I like to use the ice to tell me, should I undeflect more, deflect more, whatever. So anyway, this looks pretty good. 2 pedals up, 1 pedal down. Go ahead, please. Go. So you can see my strategy on the right side is really to focus a lot more on the pedals. On the flower position than on the basket. We will do basket lesions also, but unlike the left veins, I don't really use an olive approach on the right veins. I just use a big basket. So we've done 2. So let's rotate this. There we go. So 1 pedal up, 2 pedals down. Now after I do the 2 sets of orthogonal ones here, I actually, on the right veins, I like to do an extra flower just clocked anteriorly to get that anterior region a little bit. So what we'll end up doing on the right inferior is a total of 6 flowers and 4 basket lesions. So we've done 4. Then what I'm going to do is clock this a little bit to get this a little more anterior. Okay, let's go ahead and do that. 2 more. And then I'll show you how we do the basket here. It's not terribly complicated, but if you're careful with it, it can be done very quickly. How are we doing in time-wise? Okay. Okay, so then what I like to do is back off the sheath here, undeflect slightly, and go to a basket. As you go to a basket, you back it off a little bit more. So there it's in a basket pose, and I'd like to use a big basket. We want to try to minimize how much of the basket ends up inside the vein. Again, not so much a safety issue as it is an effectiveness issue. The wire is a little too far back.
Yes.
Okay, that's probably good. Okay, let's go there, please. It's not bad on ice. It's okay. I don't love the position of it, but I think we'll be okay because the flower. You can see the way this is sitting up. By the way, the inferior aspect of this vein will not be ablated very well in this basket configuration because remember the back part of the basket is not ablative. Okay, let's go ahead there, Martin. And one more. So one thing we could do sometimes in this situation, what I'll do is do an extra flower where I really deflect it down to get the inferior aspect of the right inferior. So I'm just show it to you really quickly. So here, that's 4, right? Yes. Okay, so let me just do one more thing here. So here I'm in the inferior aspect, deflect the sheath even more, and this will get this, let's go ahead and do 2. We'll get this inferior aspect even more. Yeah, do 1 pair. Okay, now, while he's doing the second one, I'm going to be prepared to go to the right superior. Yep. Okay. So now we're going to do the right superior. So to do that, wire back, please. I'll undeflect, clock just a little bit, advance the wire there, please.
1.
Yep. Go. Keep going. So here we can start off with this. Okay, so that's a bigger basket. If you look in the ICE, for example, ICE is really useful with the right superior to tell you that you need to clock the sheath more to get a little more anteriorly or not. Okay, I like this position, I think. Yeah, that's pretty good. Okay, let's go there, please.
Do you deliver more lesion on the superior veins than in the inferior, or you do exactly the same?
No, so the superior, my strategy typically, Melez, is to go ahead and do 2 sets of baskets. So 2, rotate 2. And then I like to figure out what to do with the flower. So with the flower, I have 2 strategies for the right superior. One strategy is sort of the quote-unquote classic of basket in position 2, rotate 2. What, we've done 2 so far? Okay, let me just rotate here for a second. I'm talking too much. Hold on. Okay, let's do that. And then the other strategy, Melez, is to say, instead of, if the vein, the right superior is too, let's say, funnel-like, as it often is, then I'll use what we'll call the 4-quadrant strategy. We go flower, anterior superior, anterior inferior, posterior superior, posterior inferior. You see what I'm saying?
Yeah.
So let's see what we can do here. So I'm going to go to a flower configuration and advance. And, you know, the right superior here is somewhat funnel-like, but it's not hugely funnel. I guess we could probably do it. It looks like it may be okay.
Yeah, this one is good.
It's not great. We could probably do it just a regular strategy. Okay, so let's try this and see what happens. Okay, go ahead.
Go.
By the way, you notice in this case, the patient, the diaphragm is not moving because we actually paralyzed this patient because it was taking so long. Normally, we don't paralyze. Normally, we don't even use general anesthesia. We just do it under deep sedation.
That was my next question.
Yeah, but usually you're absolutely right. And that's part of the reason when I do the right superior, I really like to fluoro for the right superior because, as you know, you get diaphragmatic excursion. And the catheter can just jump inside the vein. So I really like to know that. In this case, we don't have to worry about it. Okay, go ahead. So we've now done, is this the last one? Or? Okay, so the one other thing, again, just like we did with the right inferior, I like to do an additional sort of anterior one. So here in the right superior, deflected anteriorly. Go ahead, please. So we've done 8. I'm going to do 2 more. And then I may also deflect this down and go anterior inferior. Let's take a look. First, you're going to do the second lesion here.
Good strategy.
So now I'm going to deflect this. So this is anterior inferior. Let's go 2 more here, please. And then after this, we're going to do the posterior wall. Is that 1 or 2? Oh, okay. Okay. So when we do the posterior wall, what we're going to do...
So usually for the forepulmonary vein, you end up for less than 40 application, right?
Yeah. Now, let's go. Oh, hold on. I don't like this. Okay, there. Advance the wire, please. Let's go to the right superior. Left superior, I mean. Keep going. Keep going. Yeah, okay. So the very first application, we like to do it with it anchored here. So I'm clocking the sheath. I'm on the posterior wall. Okay, let's go ahead and do it here, please. So all of our posterior applications we like to do as a double hit. So just like in the vein. So that was the first application. And then we'll do a second one. After the very first posterior wall application, then we'll pull the wire back and we do the rest of it. Okay, wire back, please.
Wire back.
Yep, and then we'll go. And we like to get sort of like 50% overlap. So probably right about, let's see. Sometimes it likes to fly back and forth like this. Okay, let's go here, please. Yeah. This is another point, by the way. Ice is very useful. So you can look on ice and see if it's moving or not, and that's helpful. Okay, do the second one, please.
Vivek, we will let you finish the posterior relay because they are waiting in the other room.
No problem.
And we come back to you. Although, if you want to show us during the same time epicardial effect while you are ablating endo before we move, what do you think?
Yeah, so if you can go and come back, what we'll do is we'll map the epicardium and then we'll be ready to do the CTI because that should only take 2 or 3 minutes. Is that okay?
Yeah.
That's okay.
Yeah. So we are now ready to switch back to ECAM for Rod Tung and Joseph Kautzner case. VT ablation.
So a lot of it was far field RV.
You okay, Vivek? We move?
Okay, tak tam dejte hned na začátek ten představení pacienta.
I can hear you. We can see you.
So,
Hello, guys.
can you hear us?
And it's differential pacing because now you're getting RV
Yes.
early.
Okay, so we are here with Rod and with Jana Haškova, and in the meantime we did a lot of work. But I will start with introduction of the patient. It's a young lady. She is 28-year-old, but she underwent, or she had Kawasaki disease in the childhood, and it resulted in aneurysm, enormous aneurysm of left main and LAD. So she had a bypass at LAD and RMS. And there was a periprocedural infarction, and then she has, it resulted in a low ejection fraction with a aneurysm apical, but now she has basically akinetic the whole anterior wall and septum. We will see it on eyes. Can you keep it? She had implantation of ICD for primary prevention. She had a lot of episodes of non-sustained VT, or sometimes it's difficult to differentiate from SVT. And she's on amiodarone, so she has no more arrhythmias now. She's on full medication for heart failure, as you can appreciate here. And we started with induction with NIPS. Nothing was inducible, and so we decided to map left ventricle, and Rod will explain you what we've done until now, because it's quite interesting. It's not like a routine case of with a big scar, as we expected, maybe.
The coronary.
Yeah, sorry, we have some coronaries there. So this is ECG. You see here coronary angiography. This is obviously without bypasses. So you see calcifications of these big aneurysms. And then we have also CT angiography. So you see first a very remodeled left ventricle with very thin septum, which is scarred, basically it's a scarred tissue. And then you see a 3D reconstruction of CT angiography showing bypass on LAD and RMS. So, and these aneurysms were on direct coronary angiography. So I think that's it. So yeah, we have this intervention recorded in ICD device. So there is, there are multiple episodes, and there is also VF recorded. So then, okay.
Yep. So it's a very interesting case because it's such a young patient that we're calling ischemic cardiomyopathy, but it's clearly with that most very aneurysmal left main with the bypass. So we're dealing with an anterior septal apical infarct. If everyone can see the live ice, are we able to show that?
Can you show them ice, please?
Just to show them the morphology of this ventricle. That's really nice, the good live. And then the one special thing that we wanted to do is just to show different mapping catheters. What we have is this 111 tridecapolar linear catheter, and you can see it in real time moving along the septum right here and laying up against the septum. So that's a 1 millimeter spaced catheter on a 1 millimeter electrode, because we used to like the 222, but 111's even double that. So that's been fun, and we thought that that fits this LV dimension of 52, because if it's too big, maybe we would have chosen a grid catheter. But we also wanted to explore lines of block and differential pacing. So I think that's going to be the focus, because we're not inducible for VT. What's very interesting is the patient had that polymorphic VT VF episode, and you just heard an amazing session talking about the substrate for it. But one of our own theories is when you have a very discrete line of block, you get ventricular tachycardia. And when you don't have discrete lines of block, you get VFib or polymorphic VT. It's the same as atrial fib. Once you start creating lines, you get flutters. That's why, since we can't induce any VTs, and we look back, it actually looks like most of them might be SVT because they're 98% matches. But nevertheless, we want to explore the substrate. So we'll show you the mapping system here, and we're going to start routinely how 99% of labs start, which is with voltage mapping. So here you can see we're using 0.05 or 0.5 to 1.5 standard UPenn settings, although with a 111 catheter, you could probably reduce that because we know that increased bipolar spacing has greater voltages and shorter spacings has lower voltages. So that's a good teaching point that you can't use the same threshold for everything. But you could drop this to 0.05 and to, let's say, 0.5. Okay, so like really dense. And you see it's not really dense scar, but it's also involving the anterior septal aspects of it. And you can see where our catheter is. So now show the isochronal late activation map of this anterior infarct. And you can see the purple is the late zones. So the nose of the anterior apex is the latest area. And you can propagate this. And remember, the latest, and we mapped this in sinus rhythm, should be on the lateral wall. So show us the lateral wall. There, that's where normal should be. So that does tell you there's enough conduction slowing and discontinuous conduction that the latest is actually on the anterior wall over there. So let's go back to there. And then why don't we show a couple of the electrograms that we saw and encountered on this whole little tour around the ventricle. So we mapped this with a tridecapolar catheter, and we actually have the yellow electrograms as the His-Purkinje system. And some of the distal aspects, because you just heard Melez Hosseini talked about pruning, but maybe, and Dr. Kostner's described this as well, that some of the Purkinjes at the end of the arborization have some pathological signals. So here would be an example on real time if you can go to the recording system now and show them the review screen of the recording system.
Review screen.
It's beautiful because we can see
Review.
what you're seeing, the review screen. Great. And if you really zoom in on that, that's 200 speed for everyone to see, you can see there's a double Purkinje potential. And that's what some of the mapping looks. Go to the right and make sure it's reproducible. Just keep going. There you go. So it's reproducible. We had some sinus bradycardia over mapping, but you see there's a Purkinje and then another, almost as if there's a split P1 or P2 potential, whatever you want to call it. But that's not a normal electrogram for a Purkinje. So that could also be a source, and I think Dr. Kostner and I believe because there's some polymorphic VTVF, we should ablate that and target it, and it's also in scarred area. So that's a good target, number one. Then let's take a look at some of the double potentials that we're seeing, and then we can even confirm that in real time. As we were mapping, we developed the left bundle branch block, and it's important to keep your rhythm straight because you don't want to combine the maps. But there's a nice example of an electrogram, but go to the right. No, yeah, this is too late. Go to the beginning of it. This is where we are now. Go up to your log, and then find the earliest double potentials. Keep going above. Earlier. Wide separation ectopy. Good. So this is what the Bordeaux group described, right, with lava. Sometimes when you get a PVC, it should alert you that there's something interesting in this area. Here you can see during pacing, it's beautiful tracing actually. The paced wavefront, random pacing, not that great. Then you see there's an ectopy beat separation. Some of it may be Purkinje though. And then you see you get a Purkinje extrasystole from the tip of the catheter, and then you get separation there. Go to the right. So you can tell that there's two populations that are creating these electrograms. And then in sinus rhythm, keep going to the right. That's probably artifact, that late potential. There, that's what the electrograms look like. There's some fractionation, but some lava. And again, the idea is that lava means that you don't have a great wavefront to find the line of block. Or you don't have a line of block. There's two possibilities. But pacing far away from the line of block will be the worst wavefront. So then we decided to put another catheter retrograde, the ablation, which is retrograde, and then we were mapping the trideca transeptal, and we mapped another wavefront. So why don't you show us that, Nathan? Great. And then you can see the earliest point of activation is where the ablation catheter is, where he's showing in the mapping system. And we still had pretty much the same appearance, where it was pretty much the same splits there. So nothing that interesting. And we don't need to show too much of that. Well, then Dr. Kotzner suggested, why don't we see if the RV correlation might be nice to bring the wavefront in from the RV through the septum. And we know the epicardium is off limits for today because there's cabbage. So we're going to now do live some RV pacing and do a third wavefront for you because we've been non-inducible with 10 mics of isopril from 4 sites in the LV with triple extra stimuli. So we can't say we didn't try. We tried here in Prague and didn't happen for us. So that's why I think this is going to be meant to be more of a physiologic exhibition of wavefronts, because everyone always asks, what is the best wavefront? So let's do this live. We have the duodeca there, the trideca here, and we can even show the movements of it. And then why don't we pace the CS catheter, which is in the low septal RVOT. Beautiful. Does everybody see that live? Come off pacing.
Absolutely.
Yep, I love it. Come off pacing. I like that there's a little delay. Off pacing. And then show everyone
Beautiful.
those normal electrograms not paced. There's a far field that you see after. But now we're going to pace the RVOT, a nice example of differential pacing. And what you do is you recruit the far field, and then you have the near field, which is LV. So it actually proves the far field is RV of what we're looking at. It's really nice. So now pace the RV in real time. That is beautiful.
Perfect.
Right? So now we're
Nicely
actually mapping, if we do
anticipated.
latest activation, here, we're mapping a good wavefront here.
Yep.
But it's a nice separation, and you actually see there's almost some curvilinear activation. So we're going to map with this wavefront, because we've discovered which might be a good wavefront live, because we don't have any VT to map for you today.
Yep.
So now we're mapping with trideca. Do you want to just go into the ice and show them? And this is just for people that have never mapped with a linear catheter. We've got the elbow into the apex right here, and we're looking around, and you can see all the near field electrograms. It's beautiful. Great. And we're going to do latest deflection, which is the ILAM approach, because you're trying to get last. But actually, it looks not that interesting. And we've separated the RV from the LV, which is nice. And we're moving up here the septum. We're seeing it in real time. If you've never mapped a linear catheter, that's interesting. But
Maybe,
again,
you can see rather.
we don't see the
signals
electrogram.
in the
Yep, real
big
time
screen,
live.
real time,
Yep.
and you can have echo as a second
Yep.
screen. Okay.
So we're just going to be moving, and I love that we're looking at electrograms and not the mapping system. That's how we teach our fellows. The mapping systems don't exist without electrograms. So electrograms number one. Here you can see there's near field on 1-2, that's early, and then there's a wide split to 5-6, and it's
Right.
also near field. So there may be a line of block here within the septum. Pasquale talked about transseptal, but you can see there's maybe a wide line of block on the septum below the area we were looking for before.
Yep.
Now, unfortunately, we might not have a VT to correlate to, but I would also advocate for blading around a line of block, as we talked about yesterday. So here you can see 1-2 is near field. I don't believe that's RV. There it is again. And you have a very wide separation. And you can even tell with the linear catheter, it's going from 1-2 to 29-30 and coming back up.
Right.
So let's just keep mapping in this area. Really nice example of it. But boy, that's a great area for arrhythmia if you have this line of block. And you'll see that it might even look like VT when we're mapping this. So let's keep doing this live. We're moving up along the septum. We're counterclocking the sheath for the fellows when you're transseptal. That's beautiful right there. Very wide. How wide is that split? If you measure that from the first, electrogram. Yep, maybe 150. Okay, so that's longer than the time around the right atrium in this local area of the LV. It's pretty amazing, the amount of degrees of conduction delay we have.
Yeah.
This is great. This is beautiful, Joseph. Right, that we have another wavefront to look at. Look at that. Right, so we found a good wavefront. So next time you ask the question, which wavefront do I like? Sinus, RV, LV, BiV. It depends on the scar deceleration zone region, and you got to get close to it, which is why if you don't see anything great, there's a better wavefront to map. And we actually explored with the LV in different areas with the duodeca in the place and just paced around.
You're not in contact.
And now we're not in great contact. Good. There we go.
Are you acquiring point?
But it was
while you
Professor
are
Kotzner
moving
that
your
said we should pace the
catheter?
RV.
Rod, are you acquiring point or not?
What was, you were saying about, are we acquiring?
point while you are
On the
moving
catheter?
your DECA catheter?
Yep, this is the trideca catheter. You can see it on ice.
Yeah,
and you
but
can
I
see
mean-
1-2's.
Yeah, okay.
1-2 is early, which is why you see it in white. And then the latest is in purple right next to it, which is really nice because it's coming back to 5, 6, 7, 8, 9, 10. I'm going to just clock this down and finish this little septal map, and we'll propagate it. And everyone's going to be amazed at how much it looks like it's reentering.
Okay.
Because it already looks like it's reentering because there's rotational activation here. So I think this would be another site for us. And coincidentally, this is the area everyone likes to ablate by the left posterior fascicle for idiopathic VF.
Yeah. Can you
So
show
that's
us
not a bad area.
the 3D
Map
mapping
now?
full
Yep.
screen?
Now we'll go to the map. I love it. And then News, show them the map, and then we'll propagate it.
Yep. Yeah, thank you.
This is going to look like VT. It will look like focal activation above the line. It'll come back in and go to the purple. So go ahead and propagate that, News. Out, back around, and in.
Right.
Right? It looks like
Beautiful.
VT.
Beautiful.
It's wonderful.
Yeah.
But we don't have a VT to correlate, so it's not gorgeous, but it's beautiful. Right? But if we had a VT,
But certainly it's pathological.
right,
So
it's definitely not normal. And we've exposed it, and it was hidden. So stop pacing, and let's just show why it's a concealed line of block. And that's what we wrote about in the recent Circ paper, is if you look here in sinus rhythm, nobody is interested in this electrogram. It's low voltage, it's low amplitude, nobody cares. And everyone says, oh, it's functional. Pace it at 650, that's not even tachycardia. Pace at 650, it's not rate related. There, it's not rate related. I want to just emphasize that again.
Yep.
It is because it's differential pacing, which we never use in the ventricle, but Professor Kotzner is the one that said, let's pace from the RV, so he gets all the credit.
well, you see also on ice that the septum is really very thin, and our pacing catheter is just sitting behind from the right side.
From the eye.
And the mapping catheter is touching the septum, this basal septum from left side. So we have a very thin septum in between, and this is the scar, and it was visible also on a CT angiogram that the septum is very thin, and probably most of the scar is here in the septum going
Yeah.
to the apex.
Any
And
help,
since we're
guys, from any segmentation of the scar of imaging? Do you have these facilities or not at
No,
all?
we did not segment anything, but we see it on ice in live, online. So we basically practically never do MRI for the purpose of ablation, more for diagnostic purposes. If it's what is distribution of scars, or if there are any, but not for segmentation usually.
Okay.
We rely more on signals and more on online imaging.
So for the
So
sake of
because
time,
we're-
I think, Rod, what is the next strategy? I mean, are you going for
Yeah, so
for
let's talk
ablation?
about what we're actually going to do.
Because Milan is
So-
waiting.
Yep, so we're going to do a little pruning of the pathologic Purkinjes, and they're
Wow.
already in the scar, so why not? So the double Purkinjes will go on the distal portion of the left anterior fascicle and the posterior fascicle. We're going to ablate the area that was the anterior nose, that was the latest area that had some wide splits, and then we're going to ablate around the line of block that we discovered that was a concealed line of block on the septum.
That's perfect.
And then that'll be the endpoint.
That's
So you
good.
come back later and we will show you the result. okay?
Absolutely. We move to Milan because Carlo is impatient, and we come back.
Okay. Yeah.
Milan, do you hear us? Ah, Carlo, Giuseppe, you are
Welcome
here.
back.
Sorry for the delay, but we
I
had
was
5
sleeping.
cases.
Yeah,
No problem,
I was
no problem.
sleeping because we did finish 45 minutes ago. But I will be very short. Start measuring the QT, but we do together. Misura il QT. Okay. Okay, the QT is 503.
Congratulations.
At the beginning was 588. So we reduced the QT of 85 milliseconds. Let's go to the map. Let's
Show the
go to the
cartoon
map.
screen. Thank you.
Okay. as you see, comparing the potential before and after, we got the homogenization. We have on the right double potential before, and we have after on the left. We have the homogenization on the left. You see the voltage decreased where we found the fibrosis, but we didn't change the voltage in the region without fibrosis. So it's a very superficial lesion. The timing of the lesion, the time duration of the lesion set was about 20 minutes. The left ventricle is still, as you see, preserved. The voltage is pretty normal. And we have the homogenization on the entire surface of the right ventricle. In our mind, the procedure achieved the end point. The homogenization, lack of double potential, and the reduction of the QT time. What about the follow-up? We just observed the patient for 2 days, looking if there is pericardial effusion. Can happen, but usually it recovers spontaneously. And from the previous experience, we do not expect any more episode of ventricular fibrillation. Recurrences, we didn't see recurrences up to now. Can I have my slides? Posso avere le diapositive? Le diapositive. Okay. So, do you have a question?
No, we just want to congratulate you.
I don't
very
hear very well.
impressive result. Although we do have one question from the audience. Yeah, the question, that was my next question actually. You did this ablation on the anterior RV, and we still have this ST elevation in the inferior leads. Whether or not it is related with this abnormal
we have
electrograms.
Just notching. Can we see the EKG?
Yeah, it's still there, as we can see from.
We didn't change. We didn't change the repolarization, but it's a little different. But we deeply modified the QT duration.
Yeah, sure.
And
that was the purpose.
The heart rate is the same, so it's really the shortest QT we measured, and I think is a good result. What we know that in the next week the QT will be shorter because we observed the maturation of the lesion and see the difference in the potentials. The comparison before and after. It's clearly.
And in terms of strategy, Carlo, for the next days and next next month, is the patient will stay under beta blocker nadolol, or you will stop everything?
Yes. Okay. Before the ablation, the patient did not tolerate the beta blocker.
Right.
So we will try the reintroduction of the beta blocker after the procedure. But probably he will not take any drug.
Okay.
Because she has the ICD also. So we do not expect to continue the beta blocker therapy because it's untolerated by the patient.
Thank you so much, Carlo. Anything
Can
else you want to add?
A few things?
Yes. Because we will need to move.
Yeah, my question, my opinion is still the time to consider the QT, the long QT as a simple channelopathy? What about the risk stratification of this patient without the assessment of the substrate? I think we should take in consideration much more the substrate in the risk stratification of this patient. When we have patients with cardiac arrest and very normal imaging, we should think about hidden long QT with abnormal substrate. And once again, I understand what we provided today and in the last 2 years, it's really completely different from the opinion of centuries. So it's the time, in my opinion, to think different and to consider the assessment of the substrate probably the most important aspect in the risk stratification of this patient. This is my last comment.
Yes, we all hear you very well. Thank you so much, Carlo, Giuseppe, and all the team.
And we go back to ICAM, to Vivek, as
Vivek, yeah.
required.
I think it should be quick.
Nic, dobrý, tak to tam nech, že jsme třeba
Vivek,
prostě
the
jsou
floor is yours.
Ne, nedojížděj to.
OK. Vezmeme si angiosil, ale stačí 6 Frenchovej, jo? My máme jenom 6 Frenchovej ten, jo?
Takže
okay.
budeme jenom, takže ten review.
Okay, great. Melez, can you hear us okay?
Yeah.
Let's drop the 700.
Crystal clear.
Okay, great. So let me just tell you what we did. We finished doing the posterior wall ablation. Let's show Cardo. Make Cardo big for a second, please, so they can see it. Okay, and you'll see on the left view is the posterior wall, is the post map on the endocardium. You can see the level of isolation. Actually, you know, posterior wall means different things to different people. For me, actually, this is actually a little bit lower than I usually like, but some people like to go even lower. But you can see the approximate locations. We recorded the position on Cardo, but you know, Cardo only lets you show a couple of shadows, so that's the location. So a superior view, please. And you can see on do superior. Let's use the cardinal views. Superior. And you can see that superiorly where we are in RAO.
So it's very superior, your line. No yes. Concern of the backman?
Well, I think I'm still posterior to the Bachmans. Okay. I mean, let's show the superior one more time, please. I mean, as you know, it's not easy to ablate the Bachmans bundle.
Yeah, I know.
So, okay, REO. So I feel like we're just posterior to where the Bachmans is. You see on the REO approximately, because we did clock a little bit to bring it anterior.
You're right.
Now show a PA view, and this is the, and then show the epicardium. So we map the epicardium again. The remap. No, let's show the remap, not the first one. They already saw the first one. Yeah, that one. Okay, so that's the remap, and you can see that our lesion extended completely transmurally, and you can see again the two are right there. The shadows show you. So we feel like what we map endocardially, at least this N of 1, you can see it actually does transmit epicardially. Again, we did a double lesion at each location with probably somewhere between 20 to 50% overlap between rings.
Yeah.
So
two questions for you, Vivek. First, what is the endpoint? Do you pace inside the box? And second, could you show us some activation map of the posterior relay place to see if there is any pre-potential?
No, look, so I think we pay very close attention to electrograms. In the interest of time, just showing you colors, but the reality is there are no electrograms back here. Let's actually show them the electrograms. I mean, let's flip it over. Let's see, can we show them the Pentre, please? I think it's really important, and we can pace from inside too. Show the Pentre there, please. Yeah, good, perfect. And then can you show it to them, please? Let's show all the screens. Show the Cardo as well as the fluoro. I want them to see everything. Okay?
Yeah,
so you see on fluoro where the Pentre is. You see it on Cardo. You can see I'll just undeflect and deflect slightly. There you see it. Now if you look at the electrograms there on the Pruka system, there's absolutely nothing. Let's pace from any of them, please. Pace from some of these electrodes. So, and then drop the sweet speed to 100 so they can see. And, you know, we're not going to, there's no electrograms in here. So there is no, any activation thing in here will just be gobbledygook because we didn't even bother trying to, you know, check the annotation.
Yep.
Hopefully that's convincing to people?
Yeah, we can clearly see it. No capture, no electrograms or contact. Okay. That's perfect.
Now let's do the last thing. We want to do a CTI line. So let's pace the CS again, please, and show the fairway. And if you look, we have the fairwave now endocardially. Toshi is going to show us on ice. Here, anyway. Okay, so here you can see, let me just turn around. Okay, here you can see it on ice. We really like ice for the CTI, I got to tell you. I think it's really, really useful. I know that people don't always use ice, and I appreciate the reasons why, and they're practical reasons. But anyway, there you see, how fast are we pacing? Let's pace at 700, please. And then you'll see a couple of things. First, you'll see electrogram, both, well, let me fluoro. Okay, you see electrogram on either the atrial electrogram, and you also see some ventricular electrogram. And we're really gained up here. We can gain them down just a little bit, I think. You can see on ice there's a little bit of overlap. I'll clock it. I don't think I'm too septal. If I clock here, I don't see it, so I'm not as worried about the AV node. And now we're going to go ahead and ablate. But before we ablate, we like to use nitro. And I'm just going to show you our strategy. Can we give some pressors? Mikhail, can we give phenylephrine pressing? So we're going to give some phenylephrine, the 200 mics, please. And then we're going to give nitro. So I'm going to give 3 milligrams of nitro right now. We gave it peripherally. We don't shoot the coronaries because we know this is sufficient. And then we start our timer. Where's our timer? Okay, let's start the timer, please. Where is it? Oh, it's over there. It's on the fluoro screen. Okay. So we just gave the nitro, Melez. And again, we've tested this strategy using coronary infusion after every application. So we know that the strategy works. Whether or not it's necessary is a second, it's a different question. Some people do this expectantly, meaning they don't give any nitro only if there is actual ST elevation. I personally would rather just not worry about it, which is why I like this strategy. But I think they're both reasonable approaches. How many seconds are we at? Okay, so we gave the nitro, as I said. Now we're about 45 seconds into it. It's probably close enough. So we'll go ahead and get started. So look at the electrograms. Go ahead and start the application, please. So Melez, because of the topography, I want 3 applications, Martin. So because of the topography, I actually like to give 3 applications for each of the CTI locations. So we're going to do a triplicate. Go ahead. Okay, and then so we'll do triplicate. Actually, on Cardo, we're recording it. So can you show on the LAO view, rotate that up superiorly? Just rotate the LAO all the way up. No, the other up. I mean, from the bottom. Yeah, all the way up, 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 up. Was that 3? Okay, so that was 3. So then I like to bring it back. Let's do some overlap. And so we have Cardo. This makes it really easy. Okay, let's go again, please. Okay, go ahead. And then the nitro, as I said, I gave 3 milligrams, and I started ablating after a minute. By the way, notice the electrogram just jumped out, right, Melez?
You can see already that you have delay, even block, maybe.
Yep. Now, if we look on ice, I still think there's a proximal cuff that we probably didn't get. So I'll make one more application, one more location. Yep. So we've done 2. We've now just done the 3rd one at this location. And then we're going to deflect. I usually advance this, then pull back, and that's even closer. Now, I got to be careful I'm not getting too septal, but I think I'm okay. Let's see here. Yeah, I'm happy. Okay, let's shadow that, please, and we'll do the last set of applications. Go. We always pay attention after each lesion. Look at the AV conduction time. Make sure that it looks the same.
Yep.
By the way, we're now about 2 minutes and 44 seconds from the beginning of the first nitro. So we do 3 milligrams at T equals 0, start ablating at T equals 1, and at T equals 3 minutes, we usually give another 2 milligrams of nitro. Yep, go ahead. So it's about 3 minutes. So let's see, 1. So I'm going to give another, even though we're now done with our applications, but I'm still going to give the second dose of 2 milligrams because, you can have delayed effects because, all that calcium is still floating around in the cells. So you want those to be obviously not contraction. So here we put it lateral. And if we look at the electrodes, make those electrode numbers bigger, please, on Cardo. What you can see is 4, 5, make the numbers bigger. Can you make them bigger? Okay, on the bottom view, yeah, make them bigger there. So you can see 4 is earlier. See, 3, 4 is earlier than, say, 1, 2, which is more toward the line. So it's going around the other way.
Yeah.
And we can do differential pacing and all of that, and we'll do that. But basically, Melez, we're basically done. I want to do this quickly just to show people how to do this in a relatively, practical, quick way. And I think now we're going to go to our other room. Yeah, so now we're going to go, Peter and Honza are going to show, I think, pretty quickly. Oh, you're going to ECAM. Okay, fine. You're going to go to ECAM and then come back to us. Unless there are any other questions.
Excellent demonstration, Vivek. That was really perfect. Thank you so much. We'll come back.
Thank you.
Jo, takže potřebujeme, za jak dlouho to bude ta aféra?
So, Peter,
We can see you. And hear you
Welcome
as well.
back. Do you hear us?
Yes.
Okay, so this is to summarize, we already finished. If you remember when we left, we were doing this inferior scar. We didn't induce the clinical VT, although it was documented felt with ECG. We only induced monomorphic, which go to the central scar, and now we have the afera. So maybe we will start with the afera screen if we can. We can't. Okay, so maybe go to the review screen. So can we go to the one that we marked to show? So is this the first one? It's okay. So when we start to move around, we saw this, and this was from the beginning. This is not from the ablation. This was this idioventricular rhythm, or just small. I don't know. It's a very slow VT, or just the rhythm. You see the this was very stable. We could map this pre-systolic potential in the scar, so there was very slow conduction. I don't know whether this is automaticity or this is part of the re-entry, which is very slow, so probably it's automaticity. But nevertheless, we're able, when we start to ablate, you see the pre-systolic potential, we start to ablate and it disappears immediately. Can we go to the right maybe to slow down and see how fast it went when we start to ablate? Slow down more. And just go right, and maybe we should see the ablation. This was very stable rhythm, some automaticity in the scar. So, Vojto. Okay. So no, it starts with that's terminated before even. Okay. Anyway, so we just eliminated the core scar, which we believe is the longest SQRS electrograms. So can we go to review number 10? And we generally search for those sites when in the scar that still have a capture and a longer SQRS. So this was good for ablation. When we go next, this is also good for ablation. This is getting closer to the exit, so we still ablated here because it resembled the VT, but it's just a shorter. So we don't really extend it. We try to be conservative in terms of the ablation. And then we try to induce, and we induce something completely different. So this one is go much more septal, and it goes, it's very positive from V1 to V6, and also in V1, so this was kind of basal. I got an idea because I couldn't really find initially anything from the from the left, so I also, because sometimes if you have an inferior infarction, it extends to the right side, which is, you have to go there. So we made a brief map of the RV voltage map, and we tried to paste there. It was not that much good. It was some resemblance, so it was an inferoseptal from right, left. The right was normal signals. There was nothing really interesting. So we went back to the left side, and when we tried to induce to be kind of sure where we're going to ablate, and if we go, yes, this is the short burst of the same tachycardia, and we got this prematurity. This terminated spontaneously, but you got the idea that we are very close to the exit. And this is the best we could get, and this was very close to the core scar, but in the direction to inferoseptal basal. So we kept ablating there, and on this side we also put some additional pulses to make sure that this one is really gone. And since then we couldn't really induce anything. We got only this polymorphic VTs. Can we slow down? So this was all, and it's all terminates. So I believe, just to summarize, can we show the Afera already? We have some technical problems. So can we go bring up the Afera system just to show the size of the image? So this is, we try to really cover the core, which is the late potential VT, V1, VT2, just to ablate it, and then we extended more to the inferoseptal region when the prematurity was good for this last VT, which was monomorphic, which could be inducible. In total, just to give you an idea, we had performed about 15 or 14 RF applications, 30 seconds, and about 3 pulse field applications, just to make those one size that we believe the RF might not be enough. We just try to homogenize this, but we were very saving on pulse field, just doing RF mainly as the main one, because that's very localized. The central of the scar is no excitable anymore. There is no capture. You saw that. That's very easy to achieve even with RF. And we will wait. We don't want to overdo it. We're collecting troponin levels for these patients, and this already does quite extensive damage. So we don't really want to push it too much and try to chase VT5, VT6, VT7. I believe maybe we can be conservative and dare to do more when it turns out that this is needed. But so far, I'm quite happy because the core scar is homogenized. There's nothing. There's no excitability. And there were 3 kind of probably morphologies which somehow share the central scar, so should be good. And we wait for the clinical outcome. Any questions and comments to this?
Are there any comments? It was quite straightforward case, so maybe I'm looking for any hand. No, nothing. So if you have no more to add,
yeah,
it may be considered this case to be closed, and we probably switch back to Homolka, because there is one more case that has not yet been introduced. Thank you again. Peter, you are online.
Okay. Hi guys. Meles, Dan, can you hear us?
Yeah, I can hear you.
Okay, but no, I need to be here, okay? I need to be full, okay? So let me introduce you the case. We are using very unique technology, which is globe cardium system, which we probably know from since long time as a RF system. But now, since 2021, since December 2021, we did over 100 cases for AFib ablation using pulse field application. So can I go introduce the patient? This is a very young guy, the man with pretty normal parameters. Actually, Chadvask is 2, and he's pretty much obese. Body mass index is like 38. And he has like proximal atrial fibrillation, so we can go forward, and actually we move to the slides. Let's introduce the technology. Okay, can you get Stepan? Can you open? Okay, so globe is metallic array, which is 30 millimeters in average, and going through the 16 French sheet, and on the surface it's really high density system. This is 122 electrodes on the surface. And I said it was just designed for RF, non-irrigated RF. But what is unique for PFA is the targeting ablation. So the pulse is not volumetric, pulse is going directly to the interface of the tissue. And the system has a high density mapping capacity, so you can create voltage map, you can create activation map, and you can even pick up all this, or one of these 122 electrodes, and you can just use it for discriminated pacing, okay? So, next slide. So how to work with this? I mean, we can position the globe to each position, like PVs. We are showing today only PVI. But we did several with multiple patients, and this system is really suitable even for posterior wall ablation, mitral line, isthmus, CTI, and etc. But we are really focused now on the PVI only. So the system is working on the thermal principle. detecting the contact. So you have idle positioning of the globe, telling you you are in a good contact, and then you can pick up as the right side, the right picture, you can pick up all the elements which are in the contact, which are in the idle contact, and then pulse. The pulsing itself is several pulses taking around like 30 seconds. Next slide. And so, up to now, we did up to 59 patients with even remap. So the first in-man trial, which represents these numbers. So all veins were isolated, and we did the principle of the remaps. So we have 3 months remap in all the patients, and we got, or nearly, not all, but majority of patients, and look at that, we got really fascinating results, as usual with pulse field. But this is even much better, because when we create a substrate map, immediately post-ablation, and then 3 months after, we didn't figure out any expansion of the scar on some difference. So it was really consistent post-map, post-ablation, and then 3 months later. Next slide, please. In terms of complications or safety, it was really nice. In all these 59 patients, we haven't any single complication. It was only one, just pericarditis. It was really like inflammation. And we have just some silent stroke, but look at that. It's only 5% of silent stroke findings, which is very interesting because this sheet is really 16 French sheet, and it's usually not trivial to work with exchanging and whatever. Okay, let's go on. I'm in the status of the clinical trials. Now we will be able to present our results in the late-breaking HRS this year, which will be actually I cannot open any data. And right now we will show you the technology here on the table live. So Honza Petru is me, Alex is an assistant technician helping us to manage all the things. And we have the system here. Please focus on the sheet. So I will indicate the sheet with deflectable knob, so you can deflect very nicely, and then all the system is very stable. So sheet and the catheter is aligned, so synchronized, and is stabilized. So it's a little bit like very robust system to get very nice stability. Even we are ablating the patients without any anesthesia. So we did series of patients, more than 10, without any general anesthesia. Okay, so can we switch to the video when we deploy the system, because we are right now ready like 3 hours for you. Okay, fine. So can you switch on? So it is principle of deployment. Okay, so when we have sheet in the left atrium, then going very nicely accordingly when we look at the eyes and fluoro synchronously, and then by using the knob on the catheter, you deploy all the metallic array safely. So it's going, the array is, you can show it again, you can move it again. So the array is going from the sheet in the free space in the mid-idle, in the mid part of the left atrium, and then deploying, okay? So can we focus on our screens now, and we will show you the progress of the case. So before we were live, so we map on the chamber. So we have actually voltage map, we have activation map, we did this 2 globes in the middle. Inferior is just like GPS. So we have idea about the contact. When we are going with the globe close to the veins, for example, now we are facing on the second left the best. It's very nice position in the left inferior PV with amount of so-called flow contact. So this is general information for the operator. Okay, I can be in the contact. So let's try to investigate if I'm in the real contact. Okay. So please, can you make it contact map for me? So the guys need to, from operating room, to get the contact map. Then, Honza, if you, well, I think this is okay. So we are in. Oh, fantastic! So we are the contact. So now, guys will pick up the optimal points or electrodes for us to pulse. And actually, we have always the signals on the very right EGRAM, so all the EGRAMs are there. And now when all the elements are chosen, because the chamber is very small, okay, I need to assume the chamber is very small. So now we are ready for for pulsing.
Peter, my question is why only some of these blue sites are selected? Because
actually, I don't want to be too broad because it's paroxysmal patient, and I really don't. I need to minimize the pulsing. Okay, I really want to be focused on PV isolation because as the chamber is too small, and actually we will map after the case. You will see, and I am a little bit worried about the corridor on the posterior wall. It could be close, okay? So I really minimize the points on the posterior wall, okay?
Okay.
Great.
You also take this point?
Okay, so can we go for at least 3B, 3C, so can we get C?
2D at least. Yeah, because
on a 2C,
you need to have two rails.
Okay, perfect, okay?
Okay.
Nice.
It's okay. And
so
also,
now we are ready to pulse.
Okay.
Okay, can we go for pausing? Please, we are relaxing. So, we are paralyzed or? We are paralyzed. Paralyzed, okay, we are paralyzed, okay? So, let's go. And focus on the eyes during the pulsing.
The first application.
Okay. It's not bad, the patient is not moving.
No, don't touch it. It's okay.
Okay. So, remaining time is 20 seconds. So there will be 3 more pulses, probably. One more.
Ask them if they would consider this a single shot or not.
No, don't take it. He's crazy. So, okay, the system is announcing pulsing successfully completed. I don't care too much about the voltage, red colors, because we are showing only red colors. Can you move? Actually, so you can appreciate that those clearly single shot application. So we really get the pulsing in the one position, one application set. So we don't need to remove and change the position. Now we are ready to move to the probably left superior.
Yeah, let's go for left superior.
So can we, guys, can we move? Can we move? Okay. So it's interesting because we need to stress that all the pulses like Afera pulse, Farah pulse, every single pulse field creates temperature, but it's not on the level of ablative temperature level. Okay. So I hope that actually we all testing the pulses to not being able to create any temperature effect.
So now I'm trying to get good contact on left superior.
So okay, fine. So let's focus on the GPS globe.
I just did a really small.
No, it's very nice.
Small movement with the cutter and
when Honza, okay, sorry Honza. So when you touch, when he touch, so actually we need to stress with a very small movement, with a very discrete position of the system because it's really robust but stable. And in this case, with very small atrium, it's absolutely easy to just get another vent. So we are ready to contact map. So please can you give us contact? Perfect. So contact map is ongoing. Now we have roughly idea still on the GPS, and actually it is very, very nice map. And now we can get on the contact map. We can get the points. Actually, again, the same as Dan asked me about the expansion of the posterior. So actually, in persistent atrial fibrillation, it's nice feature that you can choose whatever you want. Okay, so I'm a little bit worried to overpulse means like to get stunned atriums, right?
This posterior stuff.
We don't like it.
Yeah, that's better.
Okay.
Okay.
This orange colors means that you need to pair the bipolar. So it's like you need to choose the pairs of the electrodes. So it could be a very nice feature, and it's still in development. Maybe it's able, when you are even scanning the vein, you can immediately have the idea which elements you pick up, okay? Which electrodes you pick up for pulsing, okay? So we are ready for pulse. Go, guys, okay? Let's go.
Yeah, Peter, prior to pulsing, or you started already? Oh.
Okay, go. Sorry.
Can you pace from these signals anteriorly, from these far fields prior to pulsing, just to see if there is still capture or not? Local capture.
We will do it later, okay? We will show you on the right side, okay?
All right.
Klidně se ještě může víc relaxovat.
Okay, so 2 pulses more. One last pulse. We will a little bit wait now to see what's happened. And actually we will see the ERAMs after the pulsing. So you see like prior to pulses are like, but I am not too much rely on the red colors, right? Okay, still activation. Can we move? Should we wait? No? Can we move? Okay.
Can we move?
Let's go. Okay.
So let's go for right
we will move to the right veins. So it's a very nice maneuver, like going clockwise. Oh look, and you have immediately contact with the right superior. So then we will follow you. Okay. So when we pick up the points, the elements, grams, so we are able to pace. Okay. So after contact map, you will ask me, then you will ask me, you can pick up your points, okay?
All right.
Which will be, in the set of ablation, not others, right?
Hopefully good contact, I think, all around the vein.
Okay.
Yes, it's fantastic. Okay.
It's not final. It will be final now. Now it's final. It's fantastic,
so
man.
Please select your points.
Select points and then be ready to say what you want to pace from. Which?
I think there is no need to pace just now because I am sure that all these bipolar electrodes would capture, but I would prefer to pulse first and then select the largest one and try to pace again from the same side. So I think pulse first.
So then we were waiting a lot. Okay, let's go for application. Okay. Sorry, time. Let's go. 30 minutes. I think we're supposed to be done. No, 30 minutes. 12:30. Yes. Actually, Vivek is worried about timing. Dan, can you help us? Do we have some more time, like 5 minutes or 10 minutes, or what we have?
We would like to go for a while to Ischemic back to conclude one case, not more than 10 minutes, and the last 20 minutes will be for you.
Okay, so please, perfect. So let's go for all veins, okay? Then we move to Ischemic, okay? And we will show you in the end the post map, okay?
All right.
All right?
So do you want to paste from something or
Do you
not?
want to paste or you forget, okay? No, we have no time, so let's move, okay? We need to
So
move.
let's go for right inferior. Yeah?
So now the maneuver is going to right inferior. Actually, on the GPS, it's still, we did the rings, so we have predefined position for the right inferior vein. It's a little bit tricky because it's very small. Okay, so great. I will show you here. Okay, on the eyes you can see position. It's nice now. It's like super, right, super. But we can see both veins, okay?
So this is right inferior. Let me find the correct.
Okay. So we have more inferior contact than super, but it's coming nicely. Now it's perfect.
Flora.
Okay. Let's go Flora. No. It's we need to catch the inferior. Perfect. So can you scan? Contact scan, please. Fantastic.
Okay, Flora for a second.
Flora.
So this is contact map. Ongoing. Should be good.
No, it will be. It's not final. Okay, let's pick up the points. Okay, perfect. Go. It's fantastic. Okay.
That's good.
Okay. Ready? No. Give her. Perfect. Go. Pulsing.
Okay, please.
Ready for pulse. Nice. Again, 30-second series of pulsing. Again, single shot. You don't need to do anything.
I don't know what people's definition of single shot is.
Single shot is this.
Okay. I mean, I think
Well,
so.
Dan, what is single shot? The question for your MLS. What would you like to get like single shot? Like only single pulse? Single position, single pulse, or what? I don't know. It's nice. You can pick out the elements, right? So it's nice.
So Peter, do you want to do the map?
Okay, so then you've seen all the veins. Look at the egrams are gone. Red colors here, fantastic. So we can move to ECAM. In the meantime, we will perform the map.
But prior moving to ECAM, I still see some far fields. Would you please pace from maybe from 6E or 6D? Or
okay. 6D.
I don't know. I can't see properly, but just to
6D.
Full output, and.
Well, but
we can pace 10 milliamperes or 15 milliamperes.
No, just pace from the elements we pass. Why we are pacing from other elements?
So can we pace like 6C, something like this?
It's too proximal.
Okay. So 7C. Can you do 7C? Okay. Pacing. So 15 milliamperes maybe. Okay. And pace.
What is the voltage cutoff there?
So
do max.
You can do pacing. So what is the output?
It's marching through. It's not capture.
No, you're capturing.
It's capturing
for sure. But you're outside.
I think
you're outside.
Yeah.
But why don't you do an active, real map, and so that way you can see where you're facing.
Can we do the map first, and then we will decide then?
All right. So now we will switch for ECAM, and we will be back in, let's say, 10 minutes, yes?
We will be back, okay?
So, I mean...
Takhle to musí držet clockwise.
Yep.
So we are back in ECAM. We can either hear and see.
So we'll give a summary of the lesion set. Professor Kotzner is remapping we all saw the concealed line of block that was unmasked with low RVOT pacing. Again, you cannot remove a line of block. Let's be clear on that also. You can modify the signals around it and maybe change the isochrone, which looks like it's normalized the physiology. But for this case, you're not going to remove it, so you still see the discontinuity. The areas of the latest activation on the other side are eliminated and reduced when you show it. But the lesion set we created on the septum was on both sides of the line of block, so you can see that on the mapping system. Why don't you just play the movie of the RVOT pacing that looked like a reentrant pattern, just to show what we based the lesion set on? Go ahead, yeah, and play that. So if you think about this as a VT, exit comes around, entrance. Exit, entrance, or it would be exit below or entrance above, but this is probably a depth boundary that determines intramural conduction in a septal substrate. Again, very nice tie-in with concealed line of block and Santangeli's transseptal conduction time. And sometimes these ones really look like a figure of 8 pattern. Then if you look anterior to the lesion set, we started doing some pruning of the distal fascicle anteriorly, which is where you see the line across the yellow lesions, which is the anterior fascicle. Those were the double Purkinje potentials that you saw. And then we extended it down this pocket and used the other initial wavefront into the anterior nose, where you had the latest activation with collision into it. So we really worked on 3 areas. This one here with the line of block on the septum, the anterior fascicle distal portion, and then the collisional part in the sinus rhythm ILAM. So we kind of used 2 to 3 wavefronts to guide the ablation strategy. And the total ablation time, how much is it? You saw that Professor Kotzner's center is 26 minutes. We're 19.6 minutes. So, and the total time here, I bet you, is less than 20 minutes. And that's our lesion set. Again, difficult case today, but we play the hand we're dealt. You know, there was no mappable VT. We were hoping to show mapping in monomorphic. But I think for a very young patient that's had 1 episode of polymorphic VT and 1 episode of VT, this is pretty good. Any questions or comments from the audience? Or anything you want to add, Professor Kotzner?
Is there any change of QRS morphology after septal ablation?
I mean, we had the left bundle block during mapping, so we had the right bundle. We have even at the beginning just scratching the area of AV node, so we had also temporary complete block. So we cannot judge now.
Yeah, we can't tell because we had bumped the bundle. And actually, of note, when we bumped the bundle, we found no His all the way up to the His, which is a perfect example of left intrahissian left bundle branch block, right? Which is not how we understand left bundle pathology. We probably bumped the left His. Stop pacing, just show us the morphology in real time. Great. And this is just real time. Yeah, there's still a big wide QRS. How wide is the QRS?
It was about 140.
We can just measure it.
Or
yeah,
more,
it's still 140.
140.
So this is perfect Strauss criteria for a woman. 140 mid QRS notching in V6, left intrahissian block. So we don't know, but we did not transect the area that we had in sinus rhythm with the left conduction system. So go back to that. That's again why I don't like to map RV pacing to start. I still like sinus rhythm to delineate the conduction system. If you can go back to the mapping system, the yellow lesion starting at the white is first deflection. This is how we changed the ILAM, which is last deflection. We did a turbo map to first, and you can see the area of yellow electrograms with the white earliest isochrone is your conduction system. And there are no lesions that cross the proximal left bundle or the left His. So we fully expected this to recover.
It's an interesting case in terms of mapping and trying to identify these lines of block. It was really amazing. This 30 polar catheter is really nice stuff to map very nicely this enlarged ventricle with not so many trabeculations. It's very nice. And we had discussion about if you are in one spot and you have one morphology and then suddenly it changes to the other, I always compare that with if you go to San Francisco to the hill and then you go downhill, so you end up in completely different neighborhood. But we discussed that Rod is persuading me, and I believe he's right, that it's not you reach the summit and then you go down, but it's because there is a line of block which is in that area. So you have very abrupt change, and that's probably explanation which after today's mapping I can buy. So it's amazing. A very nice case for mapping, more than for ablation itself. But, we enjoyed very much this. Sorry? Yeah.
13 minutes of total
13 minutes
radiofrequency.
total ablation time. Okay, any more questions or comments?
There are no questions from the audiences. I can't see any hand.
Okay.
So we would like to thank you for this nice case, educational, very intensive mapping, and congratulations.
Okay.
I think it's enough.
PA?
That's good.
That's nice.
And we go back to the final, some maybe a remap after PV isolation in Homolka Hospital, and it'll be last entry for this session.
Okay. Nice. Dan?
You are online, Peter.
Oh, Vivek is here, okay? A little bit danger, we need to go for more ablations. Okay, maybe. So we did quick map of the voltage, and you can see that despite the left atrium is not so terrible big, actually small. We didn't perform too much, the posterior corridor. So I always worried that we are creating some additional substrate for atrial tachycardia. So it's probably not too narrow. So I wouldn't go even for any roofline or something on the posterior wall. So I will leave it like it is after the piece. Okay, what?
They want to do the
I just
pacing.
want to see AP view.
Oh, you want to go for, again, pacing? Dan? Are you there?
Yeah. What was your question?
I have no questions. So, is there any questions? Are there any questions?
Why don't you go to the right and pace in there?
I can't see properly just now because your voice is, I don't know, not perfect.
My voice is not perfect?
Yeah, because there are some, I mean, from technical point of view.
My voice is never perfect.
So do you want to pace maybe from RSPV? Now we are in RSPV inside, so if you want to pace again.
Can we pace from something inside? If you want to?
Yes.
Yes.
You can do like, what is it? I can't read these numbers.
Okay.
3, 4,
we are pacing at what?
So where do you want to pace from?
It's like impossible. 5-6 E5-6. Do E5-6.
E5-6, Alex, please. E5-6, yep.
E5. E like Eve.
E,
like
5 and 6 together.
Like Christmas Eve.
So there is some kind of capture.
Right, so that's on the border.
Yeah.
So I would deflect and let's get really inside. So that's on the border of this.
It's on the line.
Right, no, I got it.
No, you need to go inside.
Right, but we need to get good contact, so I'll deflect into it and do D.
Okay.
So we are more inside now. If you see, I'm trying to push more.
Yeah, do E
So
now.
do you want to pace the same? Yeah.
Yeah, you can
right
do the
now.
same.
Okay.
And there is no capture right now.
Okay.
Yeah.
Okay, guys.
It's done.
So, any other
Yes, I
questions?
agree.
Any other questions, Dan?
No. And
No.
I may ask audience if there are any questions.
Yeah, audience. I ask audience.
No, nothing.
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 So impressive.
Okay.
Okay.
So we are done.
Okay, guys. Thank you.
Thank you.
Finally, some applause.
All right, so we are finishing the session like 15 minutes earlier than expected, and we will reconvene, I think, in 1:30 p.m.